Hi, my name is Juliana Monceaux. I am family nurse practitioner student at Texas State University, fall 2017, and this is my focused physical exam for advanced health practicum. This is my patient. He is a 45-year-old male who came into the clinic today with complaints of a cough. He got sick about 4 weeks ago. He says he thinks he caught an upper respiratory thing from his daughter. The symptoms included cough, chest and sinus congestion with adrenal fatigue. His daughter got over the sickness within a week, and he has said that he thought he had gotten over it, but the cough never really went away. And just up until the last 3 days, he's had complaints of increasing chills, some night sweats, fatigue, and a productive cough that's producing greenish yellowish sputum. He has also said he's felt feverish, but he hasn't taken his temperature. He's complained of a right-sided chest pain whenever he breathes in deeply and coughs, which he said he is coughing quite a bit. He does have a history of asthma, which is brought on by seasonal allergies and upper respiratory infections. He has a albuterol that he uses when his chest feels tight, but he's only had to use it a couple of times since getting sick about a month ago. So prior to coming in, his vital signs are 112 over 7. I'm sorry, at this time of visit, prior to the physical exam, his vital signs are 112 over 76. Heart rate is 76, temperature is 99.6, and respirations are 17 breaths per minute, and his O2 saturation is 98%. I'm going to go ahead and move forward with your physical exam. His general appearance is well groomed. He's dressed appropriately for the situation. His affect is normal for the situation. We do want to assess his orientation. Can you tell me what year it is?
2017.
And what day of the week is it?
Sunday.
Okay. And who's the president?
Trump.
Okay. So he's alert and oriented times 3. He doesn't appear to be in any acute distress, and he is answering my questions appropriately and timely. So we'll go ahead and start with the assessment. His cranium is symmetrical. There's no masses or no masses felt, no lesions present. His facial features are symmetrical. Can you go ahead and puff your cheeks and frown for me? Okay. Cranial nerves 7 are intact. Keep your eyes closed, and if you could go ahead and tell me where my finger is.
My forehead.
What side?
Left side.
Okay.
Right side cheek. Right side forehead. Left side cheek.
Okay. Cranial nerves 5 and 7 are intact. Go ahead and percuss your sinuses. Any pain felt?
No.
Okay, great. No bruise heard at the temporal artery. Okay, I'm going to go ahead and move forward with your eyes, so just go ahead and look straight at me. Oh, go ahead and just look straight at me. Corneal light reflex is present in both eyes, if you can follow my pen line. Okay, great. And just look straight over my shoulder. Cranial nerves 3, 4, and 6 are all intact with demonstration of perla and the 6 cardinal fields of gaze. Upon inspection, his his sclerae are white. There's no drainage or erythema or inflammation present in the eyes. With palpation of the lacrimal ducts, there's no drainage. I'm going to take a look inside here. Okay. Conjunctivi are clear. No signs of inflammation, drainage, or lesions present, and also no erythema present. Go ahead and take a look inside, okay? Um, Fundoscopic exam reveals that both optic discs are well defined with they're yellowish white with well defined borders. The arterial vessels are slightly smaller than the veins, which are to be expected. And the red reflex was present in both eyes. So I'm going to go ahead and move on to your ears, okay? Okay, no lesions or masses felt. Okay. The otoscopic exam finds that the auditory canals are a very light pink. They're uninflamed. There's minimal wax present in both ears. The tympanic membranes are bilaterally pearly gray in color with a bright, sharp light reflex. No erythema, bulging, inflammation, or drainage is present. I'm going to go ahead and conduct the whisper test, okay? So if I'm going to stand behind you and you just let me know what I'm saying, okay?
Cat. Cat. Bruno.
Great. So the whisper test, cranial nerve 8 is intact. So now I'm going to take a look at your nose, okay? Septum is not deviated. There's no lesions or masses present on the exterior surface of the nose. If you could go ahead and close your left nostril for me. And take a nice deep breath. Okay, let go. Can you do it with your mouth closed? Great. And now let's do the other side. Okay, great. So both nares are patent. So take a look inside here. Great. Okay. The nasal mucosa is light pink and moist. There's no crusting, drainage present. There's no mucus present. Both the medial and inferior turbinates are visible with no inflammation. They're kind of a darkish pink in color. No sores, ulcers, or lesions seen. And again, the nares are patent with his breathing. So go ahead and take a look at the mouth. I see that his lips are symmetrical. There's no cyanosis or pallor noted, so he's getting good blood flow and oxygenation. So you can go ahead and open your mouth for me. Okay, say ah. Stick out your tongue. Ah. Okay, great. Okay, good. So the buccal mucosa and oral mucosa are pink, wet, and moist. There's no lesions or ulcers or sores present. The hard palate is a whitish pink in color, with the soft palate is a light pink color, which are normal findings. There's no exudate, ulcers, or sores present in the on the soft palate. The uvula is midline. No inflammation there, and the uvula rose in midline whenever he did say ah. So if you can go ahead and open your mouth again for me. All right, just let your tongue relax. Okay, good. Go ahead and stick out your tongue. And all right, close it. Now push your tongue against my finger. Good. And against the other finger. Great. So cranial nerves 9 and 10 and 12 are intact with demonstration. And we'll go ahead and move on. So I'm looking at his throat. His throat is symmetrical. There's no obvious pulsations. Skin is even and textured. I'm going to go ahead and palpate your lymph nodes here. So we'll palpate the postauricular, the preauricular, the occipital, tonsillar, submandibular, submental, posterior cervical chain, anterior cervical chain, the deep cervical chain, and the supraclavicular nodes. No enlargement of nodes felt. Did you have any pain with palpation?
No.
Okay, thank you. So I'm going to go ahead and check for your thyroid here. So if you can go ahead and swallow for me. Great, one more time. Okay. No enlargement of the thyroid is felt, and no nodules are felt either on the thyroid there. And the trachea is midline. Sorry, I got stuck in here. And one more thing, could you go ahead and push up against my hands with your shoulders? Yeah, great. Cranial nerve 11 is intact. So we'll go ahead and move forward with the chest examination, which should be focused because he is exhibiting signs of with the coughing and congestion times a month. So I see that his breathing is unlabored. There were no retractions seen or no accessory muscles seen when I assessed him from the anterior side while I was doing my other assessments. His respirations do appear a little shallow, but again, not in any distress or seems like there's difficulty getting his breath. And again, his O2 saturations were 98%. So we're going to go ahead and start off with the chest expansion. So I'm going to go ahead and have you take a nice deep breath. Great. Chest expansion is symmetrical. Go ahead and listen to his lungs now. Okay. Take a breath. Another one. One more. One more. Again. Again. Okay, I'm going to listen to it right under here. Take a nice deep breath. And one more. And listen to his left lateral sounds. And one more. Okay. So his lung sounds are diminished throughout. In his posterior lower lobes, I do hear rhonchi on both sides, and also inspiratory crackles. And there is some wheezing in there that is not audible from my standpoint, but with the stethoscope, it is audible. So, which are all abnormal findings. So I'm going to go ahead and move forward with some percussion of his lungs here. Normal findings would be resonant lung sounds. But as I move towards the lower lobes posteriorly, actually his lung sounds do become more dull, which is seen with lung consolidation and can be found with pneumonia. Um, can you repeat after me? 99.
99.
Again?
99.
Again?
99.
Great.
99.
Okay, and I do feel increased tactile firmitus, again in those lower portions of his lobes, which is another indication that there could be some fluid in there, and is seen with lung consolidation. So I'm going to have you do one more thing. If you could take a nice deep breath for me and hold it. Okay, great. I know you said, okay, you can relax. So I know you said you get pain whenever you breathe in deeply. Did that pain stay there when you were holding your breath?
No.
Okay, great. So pleuritic chest pain often goes away whenever the patient holds their breath. And so that is what I believe we are seeing here with those patients' right-sided chest pain. So as I move to the front of the patient, I do see that his AP to transverse diameter is approximately 1 to 2, which is a normal expected finding. No signs of barrel chest on this patient. And so I'm going to go ahead and move forward with the anterior lung sounds. Take a nice deep breath. Okay. One more. Okay. And again. And again. Okay. Again, his lung sounds are diminished. Anteriorly, I do not hear the crackles as prominently or wheezing, but there is some bronchi throughout. You can do say 99.
99.
Again.
99.
Again.
99.
Again.
99.
Okay.
99. 99.
Okay. And again, there's that increased tactile firmitus. Okay. And the lung sounds actually sound a little bit more resonant on the anterior portion, but we do get some dullness right in here and right in here. So we'll move forward to the cardiovascular examination. If I could go ahead and have you lie down. Okay. There you go. Great. So go ahead and rest your arms to the side, please. So upon looking at his chest, I see no pulsations or heaves noted. As I palpate, I feel no vibratory thrills, no right ventricular enlargement. Okay, I'm going to locate the, actually I'm going to go ahead and switch to the other side over here. Make it easier for viewing. So I'm going to go ahead and locate the point of maximal impulse. Which is located at the left fifth intercostal space at the medial of the midclavicular line. So I feel that this PMI is about 1 centimeter in diameter, and the rhythm is regular. Go ahead and auscultate it. And so we want to do this for 60 seconds. Um, there we go. So in consideration of time, we won't do it for a full 60 seconds. So we'll go ahead and move forward with the auscultation of the rest of the heart sounds. So we're going to start at the aortic valve, which is located in the right second intercostal space. Okay. S1 is quieter than S2 as expected. We'll move over to the pulmonic valve, which is located in the left second intercostal space. Then we'll go down to Erb's point, which is in the left third intercostal space. Then we'll go down to the tricuspid valve, which is in the left fourth intercostal space of the lower left sternal border. And then finally, we'll go to the mitral valve, which is in the left fifth intercostal space, medial to the midclavicular line. And here, S2 is quieter than S1, which is a normal finding. Okay, so now we'll go back through and listen for any abnormalities of these valves, any murmurs, using the bell of the stethoscope. So again, we'll start with the aortic, the pulmonic, Erb's point, tricuspid, and the mitral. No murmurs heard there. Okay, great. So now we'll go ahead and move forward to the abdomen. I'm going to go ahead and lift your shirt up here. So I did notice there's a few nevi on his abdomen, but his abdomen is symmetrical, no obvious masses found or abnormalities in the contour. The contour is symmetrical and round and even. No visual pulsations are seen just with the naked eye. We'll go ahead and auscultate first. Okay. His bowel sounds are active and present in all four quadrants. We'll go ahead and listen to see if we have any bruits. Okay, no bruits heard in the aortic, renal, or iliac vessels. If I could go ahead, actually, we'll go ahead and do some percussion of his bowels. Those are tympanic as expected. Do soft palpation, any pain?
No.
Okay. And then we'll do a deep palpation. Any pain?
No.
Okay. Great. So we'll go ahead and palpate for the liver. Okay. And then the spleen. And both the liver and the spleen aren't palpable, which are expected findings. So lastly, I'm going to go ahead and have you lift your head up. Great. There's no strain in his face, and I see no masses. You can go ahead and relax. In his abdominal areas, which is testing for an inguinal hernia. Lastly, if congestive heart failure was suspected in this patient with his pulmonary congestion and cough, we could do the hepatojugular reflex, in which we would get the patient positioned supine so that we could see the jugular pulsations. And then we would put pressure for 30 to 60 seconds over his right upper quadrant. And we'd hold that there. And we would monitor to see if there's any increase in the jugular venous pressure. An increase of greater than 1 centimeter is considered abnormal. You can go ahead and sit up and face to the camera. So, this includes our physical assessment based on his history and his physical findings. The patient does have community-acquired pneumonia and will be treated for that, especially because of the findings in his lung. One thing I did assess for and that I mentioned in multiple different areas but didn't go through is his skin. And again, there's no cyanosis, no pallor. His extremities and his skin have all been warm to the touch. His capillary refill is less than 2 seconds, and there's no clubbing present on his fingers. Thank you very much.